them a double and triple dose of Degludec and glargine and found that actually Icodec was preferred or rather beneficial even with double and triple doses compared to the other basal insulin. So, going from there, the other exciting novel agent in insulin is the inhaled insulin, and I think I was told that probably in the next 6 months or so it's going to be introduced in India. And again, the inhaled insulin absorbed at the lung, and then it goes to the liver with the decrease in gluconeogenesis. On the adipose tissue, it increases the free fatty acids and lipids, and in the muscle, it increases glucose uptake. The Afrezza that's available right now is a small inhaler, as you see on the left side, with the 3 different cartridges with 3 different doses. And again, thinking about the older population, this is a useful tool for some, perhaps not all of the older population. Next, the timeline for development of the non-insulin therapeutics in diabetes care, and you see that about in 1956, the sulfonylurea was introduced to market, and then 1959, not so long after, metformin was introduced to all the markets except in the United States, where there was a lot of worry about the metformin. And then almost in 1990, the metformin was introduced in the United States for the first time. 1996 was when the first EZD was introduced to the market. In 2005, there was the first GLP receptor agonist that was approved for type 2 diabetes, and in 6, the DPP-4 inhibitor that was approved for type 2 diabetes. And then 2013 was where the SGLT2 inhibitor was introduced. So just sort of thinking about the novel therapeutics and what was the timeline helps. I think the one that really helped was in 2008 when FDA made a regulation and mandated that all the novel anti-diabetic agents must have a cardiovascular outcome trials, and that has really changed the way we think about these therapeutic agents as well as the way we use these therapeutic agents. So let's go to the incretin mimetics. And you know that incretin mimetic hormones are the gut-based hormones. And the way they work is they stimulate insulin secretion. So when you give a person glucose by intravenous injection, glucose, there is a robust insulin production as you see in the blue line. But the same amount of glucose if you give orally, the insulin production is even higher, and that is because of the effect of this incretin hormones. We see the same effect in people with type 2 diabetes, but actually the effect is less robust, and we see that also in the therapeutics that came after this incretin mimetic based on this hormone level. So what does it do? Physiological action. So GLP-1, as I said, from the gut, it increases insulin secretion. It decreases beta cell apoptosis and proliferation, and decreases glucagon secretion. But the interesting part of this agency is that there are lots of non-glycemic effects on other organs that we have now leveraged so much good in people with diabetes. On the brain, there is an effect on increased neuroprotection, decreased appetite. On the heart, there is an increased cardiac output and cardioprotection. On the gut, there is a gastric emptying that is decreased. On the liver, there is a decrease in glucose production, gluconeogenesis. On muscle, there is increased glucose disposal. And on the kidneys, there is sodium excretion. So those are the effects of a glucagon-like peptide. Glucose-dependent insulinotropic peptide is another hormone, another insulin-mimetic hormone, and that has very similar effect on the pancreas and the muscle and the kidneys, but also increases lipogenesis in fat cells and then increase osteoblasts in the bone. Physiological effect, the way we see it in the patient is that it lowers hemoglobin A1C by 1 to 1.5% by its effect on the glycemic control. It promotes clinically significant weight loss, and based on different agents, the amount of weight loss is different, but nonetheless, it's clinically significant weight loss. There is a decrease in MACE, which is the major adverse cardiovascular events. There is a decrease in the MACE in high-risk diabetes patients. There is, it slows albuminuria progression and mild GFR benefit, and in that way causes hematoprotective effect. There is a decrease in liver fat and enzymes and potential NASH or MASH benefit. And then there's a modest increase in LDL and triglycerides. Because as you know, the GI effect has been the bigger issue for the side effect, where because of the gastric increase in gastric emptying, gastric emptying and permeability, there are some side effects that we will be talking about. The dipeptidyl peptidase 4 inhibitors, and these are the enzyme that inactivates the incretin. So the production of GIP and GLP from the gut is inactivated by this DPP4 enzyme, and these DPP4 inhibitors are the ones that block the enzyme and thus increases the level of GIP and GLP in the gut. And if you look at their clinical effects on your patients, they also decrease the hemoglobin A1C by about 0.5 to 0.8%, but they do not have effect on the weight. They are weight neutral, they are cardiovascular outcome neutral, and there is no renal protective effect, although they are safe in your patients with chronic kidney disease. But also because of this difference in the effect, the GI tolerance is much better, and they do not have as much GI adverse effect as the GLP-1 inhibitor. The other important one that we use are the SGLT2 inhibitors, and they have primarily effect on the kidneys. So they have increasing glycosuria because of that decrease in plasma volume. So it works like a diuretic. And it also has effect on the liver, blood plasma, blood vessels, adipose tissue, and pancreas. At the end of it, it decreases afterload, decreases preload, and decreases fibrosis with the similar cardiovascular outcome that we see in the clinic, where there is a decrease in the hemoglobin A1C, perhaps not as robust as GLP-1 inhibitor, but they do have a decrease in A1C. 2 to 3% weight loss via glycosuria, again probably a little less than GLP-1s. Cardiovascular benefits show decrease in cardiovascular death and congestive heart failure, hospitalizations and death. And then it improves the outcomes both in people with heart failure with reduced ejection fraction, and more importantly, heart failure with preserved ejection fraction, because if you see your older population, older patients, there is an increasing number of people with this HFpEF, which are really hard to manage, and there are very few things that we can do for them. And this has been a very good addition to the management of people with HFpEF. It also slows the eGFR decline, decreases kidney failure, and decreases albuminuria, and causes decrease in the blood pressure, partly because of the volume loss and the diabetic effect. So this is sort of overall what these agents are. Why do we need to control that, right? So let's start with, why are we talking about that? And if you look at the diabetes and global aging, there is an increasing prevalence of diabetes in people with increasing age, and in high and middle income countries, it peaks somewhere around 70 to 80 years of age. So So older population does have higher prevalence of diabetes, and the countries with the highest number of people over age of 65 are China, United States, and India. So we are all going to see a lot more people, older people with diabetes. This is the data in US, but I'm pretty sure that both China is probably there and India will be there soon. That for the first time in the US history, older adults are projected to outnumber children by year 2023, 2034. And that is because the birth rate is decreasing, and this large number of people who are young now are aging. And this is going to be the problem because the prevalence of diabetes-related complication increases with increasing age group. Whether you think about any complications as is seen in blue, microvascular complication, you see it in orange, and macrovascular complications seen in green, we are going to have more complications with increasing age. Not only that, but when you compare older people with diabetes and without diabetes, older people with diabetes have higher rates of cardiovascular complications, whether you are talking about macrovascular complications or microvascular. So you have a population that is aging. The aging population has high prevalence of diabetes, and not only diabetes, but high prevalence of diabetes-related complications. So with that background, how do you then manage that? Well, let's start with the idea of who is an
mindful that diabetes is overwhelming and that people with diabetes commonly suffer from depression or diabetes distress because they have been very concerned that the diabetes that they now are diagnosed with is going to shorten their life or cause them to go blind. So diabetes is overwhelming, and we need to respect that. And then the next thing we need to do is to incorporate, if possible, if accessible, etc., these newer agents, the SGLT2 inhibitors and the GLP-1 agents plus the combinations, in order to decrease the overall cardiometabolic risk from their diabetes. So what we're going to start with is comprehensive risk factor modification. So we've already talked a little bit about the fact that it's overall lifestyle that's going to help us to help our patients stay alive a longer time. And you've heard already this morning, I believe, a lecture on the GLP-1s and their incredible impact on decreased cardiovascular risk reduction. And they have a cardiovascular risk reduction of somewhere between 10 and 18%. So what I'm now going to show you is that if I change my weight or my exercise or my diet, I have the option to improve my cardiovascular disease incidence and mortality nearly between 35 and 40%. That is greater than any of these GLP-1s, even potentially the combo, in terms of the cardiovascular risk mitigation. Now these are epidemiological data, not necessarily interventional, and so there's all sorts of biases in them, but the important point is don't leave lifestyle aside. Even if you are able to have your patients on agents such as GLP-1s and SGLT2 inhibitors, keep emphasizing a lifelong lifestyle input by your patients. In India, we have not just obesity, not just diabetes, but we have a constellation of cardiovascular risk factors that are very common, including abdominal obesity in 350 million people, hypertension in 315 million people, plus all of this diabetes, pre-diabetes, and other changes. So we need to be all about comprehensive risk factor modification. Now, that are highlighted here, we have prospective randomized data that will show that we can reduce progression to diabetes by about 50% in 1 year by just increasing fruits and vegetables in the diet. Okay? Then we have some epidemiological data and some RCT data that would show that decreasing white rice or decreasing portion size, just a regular old plate, just 1/4 of that plate being rice, really had the possibility of decreasing A1C and improving lipids, increasing dietary fiber, decreasing dietary intake, and getting rid of some refined and processed foods. So prospective and epidemiological cohort data in the Indian population specifically motivated.
One SMBG is like walking into a movie theater and walking out 1 second later, and if I ask you, well, what was the movie about? You'll tell me, I don't know, I saw 1 second. And if you go in an hour later for another second, you still don't know what happened between the first and the second. And knowing what we know now about glycemic variability, it's hard to imagine that when you're talking about an average glucose value, plus or minus, that has the same value as seeing day-to-day fluctuations, and in fact, within the same day fluctuations, because we know that glycemic variability can cause, on its own, an inflammatory response. So, we'll talk about building expertise in collaborative networks. There are opportunities for research collaborations to understand more about the heterogeneous populations and the genetic abnormalities that exist. So you've heard this information from multiple speakers, but we have a problem. It's a crisis, actually. I mean, if you think about it, we're talking about $1 trillion. The last time I saw anything that was $1 trillion, it was the stock price or the value of Apple. You know, trillions of dollars. It's hard to imagine how you would actually spend that much money and what that compares to the gross national product of many, many countries. So, we know about 500 million are living with diabetes, and that by the year 2045, it'll be almost 1 billion. The global health expenditures on diabetes are almost $1 trillion, and it's the leading cause of blindness, kidney failure, heart attack, stroke, and lower limb amputation, directly responsible for 6.7 million deaths in 2021. And as you heard just a moment ago, undiagnosed people living with diabetes are time bombs. They're developing complications even as they sit there undiagnosed. And, you know, I don't know about all of you, but I don't go see my physician as frequently as I should. And so I may have undiagnosed type 2 diabetes because I don't want to find out necessarily if I have diabetes. So this obviously adds to the complexity. And this is particularly true in low and middle income countries. So you see the map, and India has the highest prevalence after China. And so for India itself, this is a huge issue. But what about the complexity? The complexity meaning comorbidities, different responses to agents, and so on. If you look, and although it doesn't print that well on the slide, from 2000 to 2020, the percent of complex cases is going up. And it's estimated now, at least in India, about 20% are considered to be.
But a person may or may not have access to the medications or housing or the right food or understand what it is we're doing. So the thing that interferes with us getting where we need to be is access to care and affordable medications. Now, we're going to move a little bit away from very patient-centered approach to talking about what are the tools that we have in our toolkit in order to get us to optimal blood glucose control, and why is that important? So first we have to own the fact that we have known for the last 30 years that lowering blood glucose, even modestly, and even with it creeping back up, here in the UK PBS study, where they lowered A1C about 1% compared to the conventional treatment group, and they maintained that lower, about 1% lowering over 4.5 years. Okay, so this is 4.5 years of an intervention in the early 1990s. Okay, and what they saw was a 24% reduction in microvascular complications, reductions in MI, and all-cause mortality. For 4.5 years of an intervention, lowering A1C about 1%, and it's still creeping back up. So they didn't need perfection. Over now, 20 years out from this study, we are still seeing the microvascular and cardiovascular benefit, even though these two groups converged during the follow-up. So what that means is that the minute a person is at risk or identified with diabetes, you need to go after it, and you need to go after it strong. Now, the other thing I've told you is that we're seeing more and more youth onset type 2 diabetes, and in youth onset type 2 diabetes, younger onset type 2 diabetes, there is a greater likelihood of progressing in A1C to the need for a second agent. So like we do with elevated hypertension in the 160 over 100 range, what we need to do here is to treat with two are laid out the same way, where right in this sweet spot is between 7 and 9 hours of sleep. I can decrease myocardial infarction, heart failure, AFib, and I can decrease the likelihood of developing diabetes. So, eat well and sleep. And then maybe we can all go home and we don't need to have these kinds of conferences. But unfortunately, we have 589 million people in the world, 100 million of them estimated in India, and we need to figure out how to take care of them. Well, the first step will be to support this healthy lifestyle change and to use all of our community resources to support our patients. We also need to respect and appreciate that our patients aren't just people with diseases. They have a lot of things to deal with, and they may not feel very good about their ability to sleep better, or eat better, or exercise. And so we have to support them, and we have to meet them where they are and tell them it's okay that you don't like to exercise. But what do you like to do when you get up out of the chair? Let's imagine moving more. Let's imagine some fruits and vegetables that you like. And then really try to teach them as much as possible to support themselves so that we can be very compassionate with the fact that it is very challenging to change your lifestyle, and it is very challenging to live with diabetes. I would say that when I walk into clinic each time, I want to own the fact.
A sort of non-diabetes range with the current technology, the current therapies, without increasing the risk of hypoglycemia and doing it without increasing the burden. I think all of this fits with the themes you've heard today about personalization. Like in the 2 cases I showed you, and just like having a conversation of what the patient's goals are and how you might address things to reach that more narrow glucose range. And I think this really speaks to the progress that's being made. We're in such a fortunate time to have these devices and these therapies and all of these things that can help our patients live better and live fuller lives and healthier lives with diabetes. And so I think, to close, this really sums up what we've seen today too. We've talked a lot about physiology and pathophysiology and how we can try to, restore the liver metabolism, to as low risk as we can, reduce the cardiovascular risk, kidney risk, etc. All with the goal of personalizing that care for the individual and advancing the progress of our discipline. So with that, I will say we have a few minutes for questions, so thank you.
Your clinic of type 2 diabetes patients.
Yeah.
And what recent guidelines we have?
Yes.
Good question.
Good question. So the guidelines, like I really follow the ADA to say consider it in people not on insulin. So then it becomes an issue of insurance and whether it's covered by insurance. Currently, most insurances, including our kind of government insurance, Medicare, only covered if you're on insulin. So for me, anyone who's on insulin, whether they have type 1 or type 2, just in our practice, uses CGM or is offered it, and we try to get them on it. If they're not on insulin, then it just depends on their insurance, or I didn't go into it in too much detail, but we now have over-the-counter CGMs that are a little bit less expensive that some of those individuals can purchase. So it just depends on the patient. But I would say that the guideline is really anyone on insulin should be at least offered CGM.
Targets to the patient, we need to emphasize that these are not glucometer readings, which are going to be different. The capillary
Right.
will be different from the interstitial.
Exactly. No, it's a good point. And we're still, that research is ongoing. Like I showed you, we do a lot of research in pregnancy. Those sort of ideas of fasting glucose less than 95 or a post-meal 1 hour of less than 140, they don't really apply when you have CGM. We really need to look at the whole overnight period or the whole postprandial period. So your point is well taken.
Obesity is the focus, dare we say remission. All right, rather than doing these ARS, because I don't actually have the right answer here. All right, so I dare we say remission. Okay, so there are successful intensive lifestyle interventions that have been done. The DIRECT trial was done in primary care clinics in the UK, and when they were able to secure weight loss with diet and physical activity, decreasing sedentarism in these people in this randomized trial, they did great. And without being on medications, because that's the definition of remission, you're not on anti-hyperglycemic medications, these people had remission. But sadly, what you'll see here is that the minute they stop this medicine, the minute they stop this intensive lifestyle intervention, then they lose their glycemic control. So we have to remember the behavior change is very difficult, and we have to meet a person where they are. And in a 24-year-old, even if we are going to place them on a GLP-1 or give them bariatric surgery, or the two together, we still need that next 60 years of their life, they're going to need to have a healthy lifestyle, because as we just learned, they're going to lose their muscle mass and their bone mass with these GLP-1s. Now, I don't know whether or not that muscle is healthy or unhealthy, because nobody's looked yet, but I'm gonna. And So we have to really approach this person with this serious problem in a serious way. So what do we want to do? We want to sort of say, it's hard to lose weight. So it's not just easy, it's not easy to do. So we need to teach people how to lose some weight. We need to teach people how to eat better, how to move more. As Dr. Gavin would say, you need a little more of this and a little less of this. I think that's a very sophisticated approach to weight loss, all right? But it's not easy to do, all right? In order to do that, we need to take something hard, we need to teach people how to do it. Okay. Now, if we did bariatric surgery, how many in this room would offer this young woman bariatric surgery? Oh, you guys do not like bariatric surgery. All right. Well, I would say that I actually might, and I work for the VA, which is a lot of older people, and it is not adolescents. But I do a lot of research in adolescents, and I've done bariatric surgery research in adolescents, and you know what? It decreases epicardial fat. It makes the diabetes go into remission, and they do great. But I don't know how long they do great for, although I would say that compared to these adults where you saw a diabetes remission in the 60 to 70% range, depending on which kind of surgery you had, children, adolescents, actually have a longer duration of diabetes remission in the context of bariatric surgery. But you guys don't want to do bariatric surgery, so what is it that you want to do? You want,
But they all have a different meaning in diabetes care. And as a pediatrician and diabetologist, this is probably where the primary care and diabetologists are the farthest apart, because geriatricians thrive on deprescribing, and endocrinologists hate it. They just don't like that word. So we had a recent publication where we sort of repoint that to say realignment, because we are not taking it away. We are not taking it away, we are just changing it to adapt to patients' barriers. And so there is no one way of deprescribing, it's where the barrier is. First we have to identify and then change the treatment strategy so that patients do better without having the side effect.
right, and I just so appreciate that reframing, because de-intensify sort of assumes that I can take away this and then everything will be okay.
That's right.
Whereas it's not that I don't need to treat this glucose, it's that I can come up with a safer, simpler way to do it.
And the reason for that is that primarily this is used for, say, narcotics or pain medications and so forth. So those are different. Antipsychotics, be prescribed, but this is not the same.
This is a general question, and I want to address it to you and to Adinetta, because the suggestion was that maybe she should eliminate instead of good.
Yes.
And the question is that, when the DPP-4 inhibitors came along, they really sort of occupied a position as a holding action for the GLP-1 receptor agonists, which were sort of en route. They were on the way to the marketplace and to the clinical setting. But then they arrived, and they arrived, as we just heard from this very compelling lecture, with a lot of robust benefit. So my question becomes, what is the role then of continuing people who aren't at goal, who have clinical need?
Yeah.
What is the role of continuing DPP-4 inhibitors in a situation like that? Especially since we know that the number of agents that are under study right now will make the GLP-1 receptor agonist as simple, if you will, to use as DPP-4 inhibitor.
So I personally use DPP-4 inhibitors in older population in the sense of do no harm. They are very well tolerated. If I just need a little bit of lowering without making a whole lot of fuss about it, then that works very well. it certainly does not have any secondary gains, so that's what you are asking. But then there are a lot of people where secondary gain is not as important as just not rocking the boat. And then sometimes for this postprandial fix, it can help me with a little bit with the basal insulin. So, any other thoughts?
I understand. You have two components covered. You've got to cover the basal, you've got to cover the prandial. And to treat someone with basal, no prandial, makes no sense. On the other hand, the prandials that we have, they just put supplying the he wants. And basically my concern is, especially for basal, I don't want a low. I don't want a low. I can accept a little bit of a high. I do not want a low. I will tend to go to something that is kind of post-prandial. So I would probably say that this particular place in this field. I truly believe that GLP-1s, DPP-4s do have a place. They're not the most powerful in the world, they're the poor cousin. But sometimes the poor cousin is the best with them. So I use them a lot. I think one of the points that you made is very, very important. If you had the availability of Detamir, you might use Detamir in these circumstances rather than Lantus, because Detamir would give you control over the part of the day that you want, with no effect on the part you don't want.
But I do use NPH.
Yes.
Lot of NPH, and that's probably I'm the only one who is using that. And what I do is in people, even type 1 older adults, where they just are at a point where they are not able to take mealtime insulin, basal insulin in the morning, NPH in the morning. You take care of the pre-dinner numbers, you take care of the lunchtime, you still leave open the bedtime because there is the basal insulin, it may not control that big peak. But these are the people where type control is not the goal, but keeping them alive, keeping them independent and following their wish, not to have everybody else coming to the house.
That's the most important, because you can stay with one shot.
One shot? One
that most people will accept.
Yeah.
The idea that you're going to take 4 shots is absolutely asinine in the age. I think an NPH or a Detamir, the only reason I use Detamir as an example is the variability of NPH in the same individual is significant from day to day to day to day. But I use NPH like it's going out of style. Why? It's cheap. You can buy it in Walmart without a prescription, as opposed to Lantus or Toshiba or Peugeot. Now the other point that she made, which is very, very, very important, sorry, I'm going on. The basal insulin, you have to have a flat insulin. Lantus is not a flat insulin. It has a peak. If you compare Lantus to Toshiba, all the comparative studies have shown, Toshiba will give you a better fasting glucose, but a worse hemoglobin A1C than Lantus. Why? Because Lantus peak means it disposes of glucose. Ideal insulin, ideal basal insulin should have no effect in disposing of glucose. It should be simply stopping hepatic glucose. That's what the basal insulins are doing now. When you say move to morning, I agree with you. By the way, do you know when they ever use Lantus at night?
Well, it's only because there was a confusion about the clarity of the insulin. When the basals came up and they were clear like regular insulin, they didn't want to confuse patients by having the...
Actually, that's not what we do. I did a study on Lantus. We didn't want people to mix Lantus with anything else. And we knew no one would mix it with short-acting insulin that time. So we started using that time. Now people just use it better and they think that's the way it should be. It's not me. It's an insulin you can use anytime, as long as you about the same time. But it is interesting to move that in the morning. It is so important to these families that you move it in the morning. That little peak effect gives you a ton of problems.
And just to make one more point, this whole, the pattern is exacerbated when people are on steroids. So steroid causes significant post-insulin resistance. So again, if you see an elderly patient with steroid, short-term steroid, spinal stenosis, sometimes, and everybody reacts, but those are the times when the daytime numbers goes into 400s. If you do anything, the fasting goes into 40. It is uncanny. And so a lot of times you might have to just do mealtime insulin 3 times a day simply to cover that during the time when they are taking steroids. No basal, because even a little bit of basal will drop the fasting glucose. So keep an eye on that pattern when you see your patients on the steroid. 2 different eye drops, total of 14 prescription medicines. And this is actually quite middle of the road numbers in my practice. Reports forgetting to take medication infrequently, as I tell you, 2 to 3 times a week. She tried GLP-1 but was not able to tolerate due to GI side effects. A1C now is 8.2, no reports of hypoglycemia. What is the best next step in diabetes management in this patient? Add SGLT2 inhibitor, add GLP-1 receptor, and reassure patient that some GI side effect happens, keep doing it. Add basal insulin once a day, titrate up while lowering doses and stopping sulfonylurea and sitagliptin, and add ACAR. Your thoughts? All right, so add basal insulin, and I thought you guys might be a little shy of doing that. But this is the example that I was talking about, that when you realign or de-prescribe, it's not about taking away things, but it's about seeing where the problem is. So in this patient, the problem is actually too many medications, too many different timings, and so if you think about the clinical consideration, barrier to improving this patient's diabetes care and overall quality of life is excess medication burden. She's overwhelmed, and telling her to remember taking all these medications is not going to help. You can say that, hey, 2 to 3 times a week forgetting is not okay. Well, we didn't really help her. Adding SGLT2 will add on to the burden and drug interactions and side effects. Taking lifelong medication that cause significant side effects is not a good idea. It impacts quality of life. So I think GLP-1 is out. You can try different ones, but be aware of how much overwhelmed she's feeling. Although insulin injections are considered high complexity medications, basal insulin can be used to lower treatment burden and side effects. And acarbose and other medications in this class have GI side effects and low efficacy. So with that, I'm going to hand you over, Dr. Mehta,